Okay, so without further ado, kita boleh start dengan kita punya procedure presentation. So ada berapa? 5 malam ni?
Kalau boleh nak buat 5.
Okay, try to make it short and simple, but yet meaningful lah, which is I adopted. Tapi lah, boleh lah. So start lah.
First presenter, Afiq.
Okay.
Okay, I will share my screen. Can you guys see?
Yes, you can see.
Okay, my name is Muhammad Afiq bin Azmi, and I will be presenting about the blood culture and sensitivity procedure. First is, what is a blood culture test? It is a test helps to figure out a kind of infection that is in your bloodstream that can affect our entire body. It is called as a systemic infection. The test checks a sample of your blood for bacteria or yeast that might be causing the infection. Okay, what are the indications? I have listed here about the general systemic infection that can cause fever or chills, fatigue, oliguria, nausea, confusion, tachycardia or tachypnea. For the severe indications such as the inflammation in different areas of the body, small blood clots forming in your small blood vessel, a serious drop in your blood pressure or shock, and then multiple organ failure. So what do we do to our patient? First is we give introduction. So these are the introduction segment. First is wash our hands using alcohol gel. If our hands are soiled, wash them with soap and water. Apply PPE if appropriate, and then introduce ourselves to the patient, including the name and role, confirm the patient's name and date of birth, and then briefly explain what the procedure will involve using patient-friendly language, such as, today I need to take a blood sample, and so on. And then gain consent to proceed with blood culture collection. Next, important is check if the patient has any allergies, especially for latex glove.
Any? Salam.
And then adequately expose the patient's arms for the procedure. Position the patient so that they are sitting comfortably. If a bed is available, the patient can lay down for the procedure. And then ask the patient if they have any pain before continuing with the clinical procedure. Okay, these are the equipments needed. The apron, needle and collection set, the tourniquet, and then the aerobic and anaerobic blood culture bottles. And for pediatric, they have special pediatric bottle, and then sterile dressing set, antiseptic wipes, cotton ball with tape, sharps bin, and laboratory forms, labels, and transportation bags. Okay. These are the picture, the shrink and the collection set. These are the aerobic and anaerobic set with, and this is the special pediatric bottle. It is special since it needs only a few blood volume. And then the alcohol septic, antiseptic, cotton tips, and so on. Next, next we do a venipuncture, which is we first choose a vein. We inspect the patient's arm for an appropriate venipuncture site. The preferred is the median cubital vein in the antecubital fossa. Is commonly used for venipuncture. And then for areas of broken, bruised, or erythematous skin should be avoided. And areas in which two veins join should also be avoided where possible, as valves are often present. And then we position the patient's arm in a comfortable extended position that provides adequate access to the planned venipuncture site. And then we apply the tourniquet approximately 4 to 5 finger widths above the planned venipuncture site. And then we palpate the vein if you have identified to access if it is suitable, such as tapping the vein and asking the patient to repeatedly clench their fist can make the vein easier to visualize and palpate. An ideal vein feels springy, and a vein that feels hard is likely sclerosed, thrombosed, or phlebitic, and should be avoided. And then once we identify a suitable vein, we temporarily release the tourniquet, and it should not be left for more than 1 to 2 minutes at a time. And then wear an apron and wash your hands again using alcohol gel. Wear the gloves and then thoroughly clean the planned venipuncture site using antiseptic wipes. Okay. This is the picture. The preferred site is the median cubital vein. Okay. Next, how do we perform venipuncture procedure? This is the steps. There are 16 steps. The first one is label the tube with the patient's particular first, and then second is put the tourniquet on the patient above the venipuncture site if we plan to venipuncture here, and we put it slightly above, and then ask the patient to form a fist so the veins are more prominent, and then after finding the vein, clean the venipuncture site with alcohol using circular motion, and then allow the area to dry. Next is assemble needle and vacuum tube holder, and then insert the collection tube into the holder until the tube reach the needle. And then remove the cap, and then use the thumb to draw the skin tightly above 1 to 2 inch below the venipuncture site. And then hold the skin tight through step 10. Insert the needle and the bevel should be sided up into the vein at 30-degree angle or less. Next, push the tube completely onto the needle, and then the blood should begin to flow until the vacuum tourniquet is exhausted. For the pediatric patient, it is for the bottle is 1 to 3 milliliters for pediatric bottle. After we perform it, we should release the tourniquet, and this ends after opening the patient's hand. Place the dry gauze over the venipuncture site and slowly remove the needle. Apply mild pressure to the pad and then apply bandage if needed. And then properly dispose of all contaminate supplies in sharp biohazard container. And then place request form and specimen in the biohazard bag. And then we send to the...
Azik, I'm a bit confused. So you buat blood CNS ke venipuncture?
Blood CNS.
Tapi yang you punya proceeding ni bukan blood CNS. These are actually venipuncture using vacuum container lah, we call it vacutainer. Kan, this is venipuncture procedure. This is not blood CNS. Kan ada orang, tak ada orang akan present venipuncture? Got anyone present venipuncture? Tak ada.
Venipuncture tak ada.
Tak ada venipuncture lah. Okay, so this is venipuncture, dia bukan blood CNS. This is not blood CNS. So don't mix up lah. And then actually before you present, you need to know what is the method used, because there's definitely everything got few methods kan. Like venipuncture, I mean we don't use vacutainer. Actually not many hospital in Malaysia use vacutainer. I think there's none of the hospital in Malaysia use vacutainer. We do use butterfly. Butterfly is slightly similar to vacutainer, but not similar. It's actually quite different than vacutainer. I think we don't use no hospital in Malaysia use vacutainer. I think, I'm not sure. Especially in pediatric, we use drop method. Okay, most center we use drop method rather than vacutainer. So I think better kalau you present drop method. Boleh tak kalau macam your presentation ni kita tukar hari lain?
Boleh.
Boleh tak Fik?
Boleh.
Okay, so try to redo your slides, focusing on, you can include lah, I think venipuncture and blood CNS together, tapi use a proper method yang kita guna, yang you guys will come across lah dekat hospital ni, or most hospital kat Malaysia, which is the drop method and also using syringe and needle. Tapi syringe and needle pun kita jarang guna. Usually drop method lah. In pediatric, we always use drop method. So focusing on drop method of drop method to take blood CNS and drop method to take blood sampling. Boleh kan Afiq?
Boleh.
Okay, so kita tukarlah presentation lain.
Alright.
Because I'm afraid later you'll confuse lah. And then lagi satu kan, try to contact. Actually, you can ask me, of course. You can ask me. Tapi I don't want to answer. I don't want to give you the answer. Okay, what I want you to do, Afiq. Code lah hospital mana yang you guna. What type of antiseptic yang dia guna. Because we rarely use alcohol now nowadays. Actually most even in the dark pun kita jarang guna alcohol. We use chlorhexidine more now. Especially in pediatric. So you kena check lah whether what sort of solution yang kita guna. We don't use alcohol. We do use alcohol lah, tapi biasanya kita akan buat chlorhexidine in alcohol rather than alcohol 70% alcohol or 80% alcohol. So check on that and redo your presentation lah. Boleh?
Boleh.
Okay, next presentation. Kita ada 5 kan hari ni, malam ni kan?
5.
Satu presentation berapa minit
Itu saja 20 minutes per presentation.
20 minutes 20 minutes, so 5 dah 20 apa? 100 lah. So about 1 hour plus lah. Okay lah, boleh lah. Okay, next. See video, okay. Okay, proceed. Continue lah.
Can you see my screen?
Yes.
Okay. So my name is Nabila Safril, and I will present the continuous bladder drainage procedure. And this is my contents. So the continuous bladder drainage is indicated, for example, to collect the sterile urine specimens, and also to monitor the urine output of the patients, or we do it before imaging of the urinary tracts. And also we can do it for acute urinary retention, for example, in the case of benign prostatic hypertrophy or when there's blood clots that prevent the outflow of the urine. And then for the chronic obstruction that causes hydronephrosis. Next is for the initiations of the continuous bladder irrigations, that is to remove the blood clots from the bladder. And then intermittent decompression for neurogenic bladder, and lastly is for the hygienic care for the bedridden patients. The criteria that is contraindicated. So this is when the patient has trauma that is suspected with urethral injury. For example, when there is blood that is seen at the urethral meatus, or when the prostate is bulgy, that indicates the sign of inflammations. And then when there is penile, scrotal, or perineal hematomas. Next is also contraindicated when the patient has just undergo operations, and also when there is non-structure or impossible incisions during the last time procedure. There are three types of catheter. The first one is external catheter. For example, the condom catheters is for the men that does not have urinary retention problems, but they have serious functional or mental disabilities, for example, dementia. The condom catheters is a device that looks like a condoms that covers the penis heads, and then the tube leads from the condom device connect it to the drainage bed. Next type is the urethral catheter, which is further divided into indwelling urinary catheters that is most commonly used in the hospital settings, especially for the short-term bladder drainage, for example, that is less than 2 weeks. And then intermittent urinary catheters, that is a trick when the patients want to pass the urines. So the new catheter is used for each time. And then and next time is suprapubic catheters, which is inserted through a hole in the abdomen that will goes directly into the bladders. And it is done under the anesthesia and used when the urethra is damaged or blocked. The Foley catheter has an eyelet that drains the urine into the collection bags, and then there's a balloons at the tip of the catheters, in which the balloon is inflated to keep the catheters in place in the bladder. And then this is the ports in which a sterile water will be infused to inflate the balloons, and then the tube drain the urines into the collection bag. So there are several types of the Foley catheters. The first one is the straight tip Foley catheters that is commonly used. And then the second is cut tip Foley catheters, which is has a bend tip, especially indicated for patient that has enlarged prostate. And then the console tip Foley has a holes on the top so that the wire can be passed through the catheters. And then for the two-way Foley catheters, it has two lumens in which one lumen is to drain the urines into the bags, and then the other lumen is to infuse the sterile water to inflate the balloons. And for the two-way Foley catheters, in which the extra lumens is used to infuse saline solutions in order to remove the blood clots or irrigations of the bladder. Okay, so the catheter sizes measures in French gauge or FR, and for the pediatrics it uses 6 to 10 French gauge. But keep in mind that choose the smallest appropriate sizes. This is to avoid for the complications to the urethra. And then for the length, the pediatrics is usually chooses for about 30 centimeter. Okay, so for the catheterization preparations, first is preparation of the child and the families. The first step is to gain the patient's or the primary caregiver's consent for the procedures, and they should be given a detailed explanation regarding the procedure so that they know why, when, and why the procedure is done. And then for the preparations of the environment and equipment, ensure the patient privacy is maintained throughout the procedure and they are kept warm. Also ensure there is adequate lights in order to perform the procedures. The equipment that is needed is dressing trolley, catheterization bag and drapes, sterile glove, appropriate size catheter, sterile lubricant, and or xylocaine jelly shrinks, but usually in infants, sterile lubricants is used. And sterile water to inflate the balloons, and avoid normal saline because it can cause crystallizations in the tubes. And then straps or tape to secure the catheter to the leg, drainage bags, and waterproof sheet. Okay. The first steps in insertions of the catheter is first to place the waterproof pad under the patients. This is to avoid the soiling of the bed linens. And then for the female patients, they are positions in dorsal recumbent position in which the knees are flexed and the feet are apart for about 2 feet apart. And then the male patient is positioned in a supine position. Place a blanket or sheets to cover the patients and expose only required anatomical areas in order to preserve the patient's dignity. And then apply clean glove and wash the perineal area with warm water and soap or with perineal cleanser. This is to remove any feces or secretion near the area. Next, perform hand hygiene and then attach the urinary bags to the bed and ensure that the clamp is closed to prevent the urine from leaking from the urinary bag. And then apply the sterile glove using sterile technique. Drape the patient with sterile drapes and then either using sterile glove or using ungloved hands, touch the outer edges of the drapes for about 1 inch. Ensure that any sterile supplies touch only the middle of the sterile drapes and not the edges to preserve the sterility. And the sterile glove do not touch the non-sterile surfaces. And then drape the patient to expose the perineum or the penis. Next, lubricate the tip of the catheters using sterile lubricant for at least 6 inches. This is to reduce discomfort to the patients when inserting the catheters. And then check the balloon inflations using a sterile syringe. Place the sterile tray with catheters between the female patient's leg. For the male patients, place the catheter set next to the legs. And to clean the perineal area for the female patients, separate the labia with fingers of the non-dominant hands. And then using the dominant hands, clean the labia and urethral meatus from the clitoris to the anus. And then from the outside labia to the inner labia folds and urethral meatus. And then for each cleansing stroke, make sure to use new cotton swab and sterile forceps. For the male patients, gently hold the penis at the shaft and hold it at right angles to the body throughout the procedure with the non-dominant hand. Using dominant hands, clean the urethral meatus in a circular motions, working outward from the meatus. Using sterile forceps and new cotton swabs with each cleansing stroke. And then pick up the catheters with sterile dominant hands for about 7.5 to 10 centimeter below the tip of the catheters. This is so that we have a good control of the catheters when inserting in the urethra. And then for the female patients, when inserting the catheters, ask the patient to bend down gently, or can also ask the patient to cough to help expose the urethral meatus. And then advance the catheters for 5 to 7.5 centimeter until the urines can be seen to flow from the catheters, and then advance more for 5 centimeters. For the male patients, hold the penis perpendicular to the body and pull up slightly on the shaft. Ask the patients to bend down gently or to cough and slowly insert the catheters through the urethral meatus. And then advance the catheters for 17 to 20.5 centimeter or until the urine flows from the catheters. If the urine does not appear in the female patients, then the catheters may be inserted in the patient's vagina. You may leave the catheters in the vagina as a lembang and insert another sterile catheters. In the female patients, if the catheters does not advance, do not force. Instead, ask the patient to take deep breath and try again. If the catheter still does not advance, stop the procedure and inform the physicians, because the patient may have an enlarged prostate or urethral obstructions. Then place the catheters in sterile tray and collect the urine specimen if required. And then slowly inflate the balloons for individual catheters according to the catheter size using pre-filtering with sterile water. After the balloon is inflated, pull gently on the catheter until resistance is felt, and then advance the catheter again. This is to prevent the catheter to be inserted into the bladder neck instead. And then connect the urinary bag to the catheters and secure the catheters to the patient's legs using sacromic device at tubing just above the catheter bifurcations. For the female patient, secure the catheter to the inner thigh, and for the male patient, secure the catheter to the upper thigh with penis directed downward, or if at the abdomen, the penis should be directed toward the chest, and ensure the foreskin is not retracted to avoid further complication. Then dispose the supplies and remove the glove and perform hand hygiene. Document the procedure, including the patient's tolerance of the procedure, any unexpected outcomes and urine outputs. I also included the links for the videos, but these videos are about 10 minutes each, so I think you can watch it on your own later. Okay, so the steps to remove the collect catheters is first, perform hand hygiene and send out the supplies, and then apply the non-sterile glove, measure, empty, and record the contents of the catheter bag. Remove the glove and then perform hand hygiene and apply new non-sterile glove. Remove the catheter securement or the anchor device. Then perform the catheter care with foam and soaps. I will explain more later in the slide about the catheter care. And then inserts the shrink in the balloon pores and drain the fluids from the balloons. And verify the balloon size on catheter to ensure that all fluid is removed from the balloons, because it might cause pain to the patients if the balloon is inflated when removing the catheter. And then pull out the catheter out slowly and smoothly. Wrap the used catheter in waterproof pad or glove, unhook the catheter tube from the urinary bags, and discard the equipment and supplies. Reposition the patient to a comfortable positions. Ensure that the patient has access to toilet or the bedpans. Place the call bell within reach. Observe the first void or the urine output of the patients, and encourage the patient to maintain or increase the fluid intakes in order to maintain normal urine outputs. Lower the bed to the safe positions, remove glove, and perform hand hygiene. Document the procedure, for example, the time of the catheter removal, conditions of the urethra, or the fluid intakes. Also document the time, amount, and characteristics of the first void after the catheter removal. Okay. Next, for the suprapubic bladder catheterizations, it is done under local or general anesthetics. The lower abdomen is shaved, and if rigid cystoscopy is required, then the patient should be positioned in dorsal lithotomy. Or if the flexible cystoscopy is required, then the patient can be positioned in supine positions. There are two techniques. The first is open cystotomies, in which a small or typically transverse incisions about 2 finger breadth above the pubic symphysis is made. The bladder is ideally filled prior in order to have identification of the bladder easier. The rectus fascia is open, allowing access into the pre-peritoneal space, and then a small cystotomy is made and the drainage tube is placed. The tube is then secured to the bladder with a dissolvable purse string stitch. And the fascial layers and skins are then closed around the tube, in which finally secured to the skin with a temporary stitch. The second technique is the percutaneous sallinger. And in these techniques, distortions of the urinary bladder is a must for this approach. It is done physiologically, whether through urinary retentions or with the aid of cystoscopes. Cystoscopy examinations allow the direct visualizations of the puncture needle, but it may not be required. In an area about 2 finger breadth above the pubis, a needle is inserted until the urine is aspirated. Then a guide wire is placed through the needle into the bladder, and then the needle is removed. The dilator is advanced over the wire, enlarging the tube. And the dilator is then replaced with a shave. Then the wire is removed and the catheter is placed through, and then it is placed through the shave, which is then peeled away. And the catheter balloon is then inflated and the catheter is gently withdrawn until a slight tension is felt. The catheter is then connected to the catheter drainage system and secured to the patients. I think I would like to show a 1-minute video. Can you see this video?
Yes.
Okay. Okay, so first step, the needle is inserted into the bladder and then removed, and then the guide wire is inserted through the needle, and then the dilator is inserted to enlarge the tract, and then the guide wire is removed and the catheter is inserted through the dilator. And then the balloon is inflated using sterile water, and then the dilator is peeled away, and then the catheter is connected to the urinary bag. And yep, that's it. Okay, so regarding the catheter care, about the mental care, it is cleansed with soap and water around during the daily bathings for maintenance and for cleanliness. And then if the leakage occurs around an established suprapubic catheter, for example, that occurs after about 6 weeks after placements, or for the transurethral catheters, then the catheter can be replaced with a new catheter that is larger by 2 to 4 French gauge. To monitor the obstructions or to prevent backflow, the catheter and the collecting tubing should be free from kinking and fixed to the patient's legs. The collection system must be positioned below the level of the bladder at all times, so that the urine can flow into the urinary bag. And then regarding the changing catheters, as a rule, indwelling catheters actually should not be replaced routinely. For the suprapubic catheters, they are generally managed by the operating surgeons and are not changed until a tract between the bladder and the abdominal wall is established, in which it requires for about 4 to 6 weeks. For catheter removals, it is indicated to prevent it is done to prevent the catheter-related urinary tract infections, or when there is when the indication for insertion is no longer met. So the complications with the continuous bladder drainage is it might causes catheter-associated urinary tract infections such as urethritis, cystitis, pyelonephritis, and transient bacteremia. It can also cause paraphimosis, especially in children, in which the foreskins appear to be swollen and painful due to the failure to reduce the foreskin after the catheterizations. And next complication is creation of false passages, in which the catheter pass through the urethral walls. Next is urethral strictures or urethral perforations, bleedings, and also can cause non-infectious complications such as accidental removal, catheter blockage, gross hematuria, or urine leakage. And this is my reference. Thank you.
So can we proceed to the next my presentation?
Assalamualaikum. Assalamualaikum. Dengar tak?
Salam, dengar.
So you're presenting on CBD kan? Again, this is the same thing occur again and again lah dalam like similar to your previous seniors. I think a lot of the presentation, first, not actually the source mainly are from adult punya source. So for example kan, you cakap you masuk 7.5 cm and then apa tu, forward another 5 cm. these are actually macam adult source. I'm not sure whether this is you get it from pediatric ke tak. It's like a mix up, like a mix up. Your picture may look like pediatric sebab usually what we did is, so I also did the same. You can type kat Google untuk picture, and untuk image you tak Google image CBD in pediatric for example. Tapi bila you buat CBD, bila you buat your presentation, most of the time either you adapt from your seniors ataupun you just type CBD. So you either you copy paste atau you rephrase and put them on your slides. Tapi a lot of slides is not really like specific for pediatric. Faham tak? Am I right ke ataupun just my suspicion? You guys dengar tak? Hello?
Dengar doktor.
Itulah. I'm not sure because I always mix. I mean usually lah bila procedure presentation kan, I'll end up confused. Sama ada is this the new way of doing procedures ataupun actually there's a mix up of like adult dengan pediatric punya procedure, because definitely we do CBD both in pediatric and neonates, in adult. Cuma in pediatric kan, the way we do it slightly different, and how we do it pun slightly different. The indication also different. Macam contoh you've mentioned about intermittent catheterization. I also you mentioned early on kan, you mentioned about intermittent catheterization. Yang tu pun you mention because want to reduce retention kan, urinary retention, because that's not the aim of intermittent catheterization. Because later on because of course procedure ni dia tak masuk exam. I mean we don't really ask. We can actually ask them in theory, tapi we rarely lah. We don't actually ask procedure in theory, the theoretical part of the procedure in exam. Tapi you may make mistakes lah. Tak apa, it's okay. Actually it's my mistake juga. Sepatutnya I kena tengok you punya slides. Cuma problem dia memang tak sempat lah nak tengok slides. Tak apalah. Why not you send your slides after we finish kan, or the class send your slides. I may give you some comment on the slides, and hopefully you can improve, or you can tell your friends how to improve on that. So yang ni the whole batch ke? The whole block ke? The whole all the people in the block ke ataupun only like small groups?
Small group.
Oh ya ke? So ada group pun dia akan present the same thing lah kan? Sebab I'm not sure lecturer lain nampak tak benda ni. Because we haven't discussed about this lah. Tapi this is the same problem occurred every time. Without miss, it's occurred again and again. Tapi among the lecturers pun kita tak pernah bincang about this. Tapi nanti I raise the concern untuk ada lecturers lah. Maybe diorang pun tak terperasan. Anyway, boleh proceed lah dengan next presentation. Cuma bagi me your slides later. Okay, continue.
My presentation.
Sorry. Oh, the other thing we can do is our next class is bila? Yang dia ada for presentation tu?
Esok pukul 12.
Pukul 12
Kena nak buat bila?
Esok tak, memang kena buat esok. I dah tak ada masa lain dah. Because saya tengah pindah rumah sekarang. So saya memang nomad lah sekarang ni. Because I stay in Kemaman, tapi because of the PKP, so hospital dengan kuliah kata all staff yang duduk Kemaman kena sewa rumah dekat area Kuantan, tak boleh commute. So I'm struggling lah now, macam nomad sana kemari. So tu so tak apa. Boleh tak kita postpone kelas hari ni? You all give your slides. I'll try to comment them. I'll try to comment. Tapi I'll try to comment by tonight lah. Send now. I'll try to comment by tonight, and then hopefully pagi esok you boleh update, you boleh review your slides and then present all tomorrow, tapi 10 minutes each. Just 10 minutes each. So kita ada macam 9-90 minit lah. So less than 2 hours kita can complete the whole 9 presentation. Because procedure presentation will be marked tau. You guys dapat 10 markah daripada procedure presentation untuk you punya final mark. So this is very important lah. Okay? So just give me your slides, email me. My email is muhdalwi@gmail.com.
Okay, Doktor.
Okay?
So Doktor 10 minit je?
10 minutes je. So cut your slides into maximum 3 je. 3 slides je. 4 slides. Okay, 4 slides maximum. Okay?
Okay.
Okay.
Esok ke-12 Doktor?
Esok ke-12, yes. Tapi email me your slides lah. Okay. Okay, guys.
Alright. Thank you, Doktor.
Okay, sorry lah.
Nanti semua send slide dekat dalam group WhatsApp tau. Nanti saya email kat Doktor.
Okay. 4 muka surat
Empat je. Macam mana nak buat 4 je?
Ya Allah. Tak, dia tak betul lah.
Okay, bye semua.